Well, we're going to try to cover a lot of territory tonight. We're going to spend the first half an hour or so reviewing the common electrolytes that you have on your biochemical profile and what it means when they're increased or decreased and why. So we'll do that in the first half an hour. Then we'll spend the second half an hour talking about clinical markers of GFR. We'll cover some old territory, things you already know, like BUN and creatinine, and talk a little bit about clearance tests, and then end up with a review again of SDMA, reinforcing some of the stuff that Graham already told you. So let's start with the electrolytes. There's about a half a dozen electrolytes that you see on your profile, and it's really important to understand that electrolyte disturbances are not diseases in and of themselves, right? They're really just manifestations of some other underlying disease that's causing the electrolytes to be abnormal. So you should always keep that in the back of your mind. Sometimes we get really focused on trying to manage the electrolyte disturbances, but we can't lose sight of the fact that we have to work on diagnosing the underlying disease that's causing them. Before we start talking about the individual electrolytes, I want to show you this picture, which is a summary of the various electrolytes and their concentration in extracellular fluid and intracellular fluid. So when you draw a blood sample and send it to the lab, you are basically sampling extracellular fluid. So for certain electrolytes, like sodium and chloride and bicarbonate, those concentrations that you get on your biochemical profile resemble very much what's in extracellular fluid because you're basically sampling extracellular fluid. However, for two of the electrolytes, potassium and phosphorus, you'll notice that they are primarily intracellular electrolytes. So the concentration of potassium in the extracellular fluid or in the blood is about 4. But if you were to sample intracellular fluid, it'd be 140, very high. And likewise with phosphate, if you were to sample the extracellular fluid, it'd be about 2 milliequivalents per liter. But if you were to sample intracellular fluid, it'd be as high as 40. And the reason I mention that is the interpretation of the serum potassium and the phosphate is influenced by that. So you're trying to decide what's going on with the animal's total body potassium or phosphate by looking at a very small portion of what's in the body. So it's a little more challenging to assess the potassium and the phosphate in many instances. But all of the electrolytes can be challenging in their own right, for sure. So we'll just go through each of them. And we'll start with sodium, and we're going to focus on dogs and cats. And each species is going to have, a range for their normal values. But for my purposes, it helps to think of what's kind of the average. And so for sodium, the average sodium in a dog is about 145 milliequivalents per liter. And in cats, it's about 156 milliequivalents per liter. So cats, on the average, have a higher sodium than dogs. Why? I don't know. It's a species difference. The most important thing to remember about the serum sodium concentration is that it's really not telling you about the body content of sodium, really. What it's telling you about is the amount of sodium relative to the amount of water that's in the body fluids. So really, in most instances, when the sodium is high or low, it's telling you that you have too little water or too much water in the extracellular fluid rather than too much or too little sodium. So think of it as an indicator of how concentrated or dilute the body fluids are. So in virtually all instances, when you have hypernatremia, you also have hyperosmolality because sodium and its two main attendant anions, which would be chloride and bicarbonate, constitute pretty much the major active osmoles in normal animals' blood. On the other hand, hyponatremia almost always, but not always, means hypoosmolality. There's just a few exceptions there. So I'll just give you one example. With severe hyperglycemia, that will attract water into the extracellular fluid or the plasma, which will dilute out the sodium. So there's an example of a situation where you're hyperosmolar from hyperglycemia, but you actually have a low sodium. So hyponatremia doesn't always mean hypoosmolality, but it usually does. When you look at the serum sodium concentration of a patient that's hypernatremic, there's really only, and this is very logical, there's really only 3 ways that can happen. How can you make the amount of sodium relative to the amount of water go up? Well, you can do that if you lose pure water, right? It'll make the sodium concentration go up because the amount of water's gone down. If you lose hypotonic fluids from the body, which is what happens when you have animals with GI problems, vomiting, diarrhea, when you have animals that are losing large volumes of water in the urine, polyuric individual, those losses are typically hypotonic losses, which tend to then concentrate the sodium in the blood. And the same is true with third space losses when you have effusions, peritoneal or pleural effusions. The last way you can increase the serum sodium concentration would be if you did add salt to the animal or add impermeant solute. That is extremely rare, very rare. Only times I've heard of it are some examples where you've got some crazy Labrador that goes swimming in the ocean and drinks a bunch of salt water. That can do it. A while back we had some case reports in the literature of people who made homemade Play-Doh with flour and water and salt, and the dogs ate that. That was a gain of impermeant solute. So that can happen, but it's quite rare. Quite honestly, in private practice, the situations that cause hypernatremia are usually hypotonic losses of fluid either through the GI tract or the kidneys. Hyponatremia, unfortunately, is a little bit more complicated to assess. The low serum sodium concentration can be caused in 3 different situations. One with low volume, one with normal volume, and one with high volume. The most common situation is when you have severe hypovolemia, which can be caused by GI losses, urinary losses, or third space losses. Now, if you'd been listening to what I was said earlier, you're probably saying, wait a second, on the previous slide, you just said you're gonna get hypernatremia when you have hypotonic losses, and now you're telling us that you can get hyponatremic with hypotonic losses and hypovolemia. How can that be? That's contradictory. It is contradictory, but the thing to remember, and I'm just going to jump ahead one slide for a second to talk about this, is when you have severe volume depletion, you get antidiuretic hormone release. Now, you probably all remember from school that the primary stimulus for ADH release is hyperosmolality of plasma, and that's true. It causes a very little change in plasma osmolality, causes a big change in ADH. But the second most important stimulus for ADH release is severe volume depletion. And so when the animal gets severely volume depleted, even if it's for loss of hypotonic fluids, you then get this non-osmotic stimulation of ADH release, which impairs water excretion. And if the animal is thirsty and continues to drink, it can't excrete that water as well. It dilutes out the sodium, and you do get hyponatremia with severe hypovolemia. So it's not really contradictory. It's a matter of degree. Mild hypovolemia with hypotonic fluid loss, you're going to get hypernatremia, but when you get severe volume depletion with hypotonic loss, you will actually get hyponatremia because of this non-osmotic stimulation of ADH release. So that is a little hard to understand until you parse out the pathophysiology. The 2 other situations, and that's the most important one and the most common one clinically, okay? With normal volemia, you can see mild hyponatremia. Common example is psychogenic polydipsia, where the animal is basically drinking because there's something wrong with his head and drinking water beyond what he needs and diluting out his sodium concentration. The last category where you can see hyponatremia are situations with actually excessive extracellular volume. But these are 3 unique situations: liver disease, glomerular disease or nephrotic syndrome, and congestive heart failure. There are 3 situations where actually the extracellular fluid volume, which consists of the plasma volume and the interstitial volume, is actually increased due to increased interstitial volume, whereas the plasma volume itself is actually decreased, and sending a signal in some way to the kidneys that you need more volume. And when the kidneys think you need more volume, the only way that they know how to fix that is to retain sodium and then water with it. And these are all situations where you have activation of the renin-angiotensin system. With congestive heart failure, the pump is not working properly, decreased perfusion of the kidneys. The kidneys think, oh, we're hypovolemic, we've got to fix that. But really the problem is not that you're hypovolemic, it's that the heart's not pumping adequately. With glomerular disease or nephrotic syndrome, it's a loss of oncotic pressure. You've lost protein in the urine, and you've decreased the oncotic pressure. There's decreased perfusion of the kidneys, and they think, oh, we need more volume, so we're going to reabsorb more sodium and water. but that's not the root of the problem. The problem is the loss of oncotic pressure. And with liver disease, it's a combination of factors, including hypoalbuminemia and also things like ascites associated with portal hypertension. So it's pretty easy with the hypervolemia. Just remember those three things: severe liver disease, glomerular disease, or congestive heart failure. So hyponatremia is kind of complicated. We already talked about that. So that's your serum sodium concentration. Serum chloride, chloride concentration normal in dogs about 110, and normal in cats about 120. The first thing I want you to notice here is there's not a one-to-one relationship between sodium and chloride in the blood. And why is that? It's because the sodium in the blood is balanced not just by chloride, but by chloride plus bicarbonate. Whereas in a fluid like 0.9% saline, it's 50% sodium and 50% chloride. And if you give that to an animal, you're actually giving them an excess of chloride relative to what they have in the body. And that's because in the body, the sodium is balanced not just by chloride, but by about 110 of chloride and about 20-something of bicarbonate. So it's important to understand that, and also to understand that in the kidney, when you reabsorb sodium, there's really only two anions you can reabsorb with that, and that's chloride or bicarbonate. And when there's a deficit or excess of one or the other goes in the reciprocal direction. And if you understand that relationship, you can sort through a lot of disturbances of both chloride and bicarbonate. So just remember, because the ratio is not 1-to-1, if you lose equal amounts of sodium and chloride, you're creating a disproportionate loss of chloride. If you gain equal amounts of sodium and chloride, you're having a disproportionate gain of chloride because the ratio is not 1-to-1 in the body. So what causes hyperchloremia? Well, small bowel diarrhea is a good example because you have an excessive loss of sodium relative to chloride, because when in that diarrhea fluid, the sodium is balanced not just by chloride, but often by a lot of bicarbonate. So you can get hyperchloremia. In fact, typically the acidosis of small bowel diarrhea is a hyperchloremic metabolic acidosis because you're losing a lot of bicarbonate in the diarrhea fluid relative to chloride. Excessive gain of chloride relative to sodium is another cause of hyperchloremia. A good example there, and one that I think is worth remembering, is 0.9% saline. So when you infuse an animal with normal saline, it's got 154 or whatever it is, 156 milliequivalents of sodium and an equal amount of chloride. But in the animal, it's not that way. It's maybe 145 or 155 of sodium, but only 110 or 120 of chloride. So you're giving that animal excessive amounts of chloride. And if you're infusing that into an animal at a constant rate, what's going to happen in the kidneys is you are going to drive down the bicarbonate and drive up the chloride because there's more chloride circulating around than bicarbonate, and you'll acidify the animal. So that's why if you've ever heard that 0.9% saline is an acidifying solution, and that's because you're giving the animal an excessive amount of chloride and the bicarb is going down, so you're getting an acidosis in effect. However, you stop infusing that and the kidneys will rapidly correct that and bring the bicarbonate back up. The only other situation where you see hyperchloremia is with excessive chloride retention by the kidneys as a compensation for chronic respiratory alkalosis. So what happens with chronic respiratory alkalosis is the PCO2 goes down, and as that happens, the pH goes up. When the pH goes up, you get decreased secretion of hydrogen ions in the kidney, and when that happens, you get decreased reabsorption of bicarbonate and reciprocally increased reabsorption of chloride and hyperchloremia. On the other side of the coin, hypochloremia. Most common causes are vomiting of stomach contents because you lose a lot of chloride relative to sodium because of the hydrochloric acid secreted in the stomach. Very common cause of hypochloremia. Loop diuretic administration like furosemide. Furosemide causes the kidneys to lose equal amounts of sodium and chloride, but remember, that is creating a disproportionate loss of chloride because the normal ratio is not 1-to-1 in the body. So loop diuretics tend to cause hypochloremia because of that. And then as far as compensation for acid-base disturbances, we have the reciprocal situation here when you have compensation for chronic respiratory acidosis. So with chronic respiratory acidosis, the PCO2 goes up, right? When the PCO2 goes up, the pH goes down. When the pH goes down, the kidneys secrete more hydrogen ions, and when they secrete more hydrogen ions, they reabsorb more bicarbonate. The bicarbonate goes up, the chloride goes down. And that's a normal compensatory mechanism. And I should remind you guys that Graham is going to provide you with the PDF of all these notes, so you don't have to take any notes. You'll get all of this in writing, and you can just try to think through things and not try to write anything down. So let's talk about potassium now. So potassium is one of those intracellular ions, right? Okay, so normal value of potassium, I have here about 4.5 average for dogs and cats. Maybe 3.5 to 3.7 to 5.3 to 5.5, but an average about 4.5 or so. Now, with the intracellular solutes like potassium and phosphate, I like to think of that in terms of their extracellular fluid concentration, that's what you're sampling in the blood, right, is influenced by three things. It's influenced by intake, by excretion, and with potassium, you can, in dogs and cats, pretty much think of all of the potassium going out of the body in the urine. A little bit goes out in the GI tract, but really not significant amounts. The main way it gets out is through the kidneys. And then the other factor that affects the extracellular fluid concentration is what we call translocation between intracellular and extracellular fluid. So if you think about it, the extracellular fluid concentration of potassium is about 4, the intracellular concentration is about 140. So anything that causes movement one way or the other, if you move potassium from intracellular to extracellular fluid, you can create hyperkalemia pretty rapidly. And vice versa, you can cause some hypokalemia. So these are the three things that conspire together to control the serum potassium concentration. Looking at the example of translocation, what are the things that affect the translocation of potassium between intra and extracellular fluid? Acid-base balance is a big one. In general, acidosis, you tend to move hydrogen ions into the cell to be buffered by intracellular buffers, and potassium ions come out. So acidosis tends to cause a little hyperkalemia, especially mineral acidosis, not so much organic acidosis like lactic acidosis. Alkalosis does the opposite. So the hydrogen ions come out of the cell to deal with the high bicarbonate level, and then the potassium goes into the cell, and you tend to get hypokalemia. Insulin is a great example of something that causes translocation of potassium from extracellular to intracellular fluid, because when you give that DKA patient insulin, not only do you drive glucose into the cells, you drive potassium into the cells. And as you've probably observed, if you've treated DKA patients, if you don't pay close attention to their serum potassium, they get hypokalemic very easily. So you've got to supplement them with potassium. Catecholamines also contribute to the movement of potassium intracellularly. And then acute tumor lysis syndrome is a syndrome that occurs when you're treating a patient with a heavy tumor burden, like a patient with lymphoma involving the liver and internal organs, and you treat them with chemo. When those lymphocytes die, they release potassium and phosphate and other things from inside the cells into the blood and can cause hyperkalemia and hyperphosphatemia. It's called acute tumor lysis syndrome. So that's how translocation can affect serum potassium. As far as looking just at hyperkalemia, again, we look at intake, we look at translocation, and we look at renal excretion. So what could cause hyperkalemia? Well, increased intake alone, if it's oral, probably really not going to cause hyperkalemia. And that's because when you take in a potassium load orally, hormones are released, things like insulin and catecholamine, that help that potassium load that's coming in the portal circulation from the gut to move that potassium into cells. So that's, I always jokingly say, that's why drinking a big glass of orange juice and eating a banana for breakfast doesn't kill you. It's because all that potassium that's coming in the portal circulation, those hormones, catecholamines and insulin, move that into the cells so you don't get hyperkalemic. So you really can't cause hyperkalemia by eating a lot of potassium. Now, on the other hand, if you have a bottle of fluids and you supplement that with potassium and it's going IV, and you make a mistake and you put too much potassium in the fluids, you certainly can cause hyperkalemia that way, but that's parenterally. We talked about translocation, so anything like acute mineral acidosis or insulin deficiency or acute tumor lysis syndrome, any of those things can cause potassium to move out of the cells or to not be able to get into the cells in the case of insulin deficiency. And a very important cause of hyperkalemia, probably the most important cause up here, is decreased renal excretion. So whether that be a post-renal thing like urethral obstruction in a cat or a ruptured bladder, or whether it be oliguric acute kidney injury, or whether it be Addison's disease or certain drugs that inhibit urinary excretion of potassium, like ACE inhibitors or potassium-sparing diuretics or beta blockers. So those things can all cause decreased excretion of potassium. So these are, again, looking at those three things that converge upon the extracellular concentration: intake, translocation, and excretion, and thinking about those, what can cause hyperkalemia, and these are the main ones. The most important one, decreased renal excretion. Pseudo-hyperkalemia, maybe we'll just mention real briefly, is a situation where it doesn't happen in the body, it happens in the test tube. So if you have an animal with severe thrombocytosis, like platelet counts over 1 million, and you draw blood from that animal, and while that blood clots in the tube, the thrombocytes or platelets can release enough potassium to cause mild increase. It's not happening in the animal, it's happening in the test tube, so it's not relevant to the animal. Likewise, most dogs and all cats that I know of, unlike people, have red blood cells that have a low potassium content. Our red blood cells have a high potassium content, so that varies by species. But within the species dog, there are a few breeds, mainly the Asian breeds, the Akita, the Shiba Inu, and the Yindu breeds do have high potassium red cells, and hemolysis can cause hyperkalemia. But again, it happens in the test tube when the hemolysis occurs, that you see, then you measure that and you get a high potassium. It's called pseudo-hyperkalemia because it's happening in the test tube, not in the patient. Hypokalemia, we look at the same things. We look at intake, translocation, and excretion or loss, either through the GI tract or the kidney. So in an abnormal situation where you have decreased intake, in general, animals with, it's just a matter of partial anorexia, that alone probably will not cause hypokalemia because you'll have mobilization of intracellular stores. But it usually takes a combination of decreased intake, maybe vomiting, maybe loss of muscle mass, maybe polyuria, and all those things converge together and you could get hypokalemia. But decreased intake alone, even for a fairly long period of time, the intracellular stores will prevent the hypokalemia. Translocation, just the opposite of what we talked about before. So here, alkalemia. So with alkalemia, the hydrogen ions come out of the cells, potassium ions go in, you can get mild hypokalemia. Insulin and glucose. So when you treat that DKA patient with insulin, the potassium goes into the cells as well as the glucose, and you get hypokalemic if you don't supplement. Increased loss. We said in the normal situation, the urinary route of loss is the main way potassium gets out. But if you have a disease situation like vomiting and diarrhea, that can cause sufficient loss of potassium to cause hypokalemia. So on the loss side, you've got to consider both the GI tract and the urinary tract. Okay, bicarbonate, normal in dogs and cats about 21 or 22, humans about 24 milliequivalents per liter. So the bicarbonate on the profile, the general rule of thumb that I'd want you to remember is when the bicarb is low on the profile, generally means metabolic acidosis. When it's high, it generally means metabolic alkalosis. That's a pretty safe bet. But it's also important to remember that you can see an increase in the bicarb in the blood as a compensation for respiratory acidosis, and you can see a decrease in the bicarb as a compensation for respiratory alkalosis, like we talked about earlier. So those are other reasons you can see changes in bicarb. But as a general rule, most dogs and cats that are ill, that have a high or low serum bicarbonate, it's typically due to metabolic alkalosis or metabolic acidosis. But if you really need to know what all's going on with the acid-base balance, you're going to have to look at a blood gas. Okay, calcium and phosphorus. I like to think of calcium as phosphorus as being two electrolytes that are controlled by three hormones acting on three body systems. The three hormones are PTH, calcitriol or active vitamin D, and calcitonin acting on kidney, bone, and gut. Really, calcitonin is a minor player. Its main role is to minimize hypercalcemia after a protein-rich meal by inhibiting calcium and phosphorus release from bone. It's really not a big player. So really, it's mainly PTH, vitamin D, and the kidney, the bone, and the gut. So in PTH in the kidney increases calcium reabsorption, but it decreases phosphorus reabsorption and increases phosphorus excretion in the kidney. And PTH also acts permissively in the bone to increase release of calcium and increase release of phosphorus. It acts permissively with vitamin D in that role. Vitamin D's main role, however, is to act on the gut to increase both calcium and phosphorus absorption from the gut. So if you look at these three groups of two here, you'll see that what happens, what the system does when you add it all up, is it mobilizes calcium in the body, and at the same time, it lets that phosphorus that it mobilizes along with the calcium go in the urine. So it's a way of getting the calcium level back up to normal, but not getting hyperphosphatemic. So when normal total serum calcium is about 10, 9 to 11 milligrams per deciliter. But remember, on the profile, you're getting the total calcium concentration. And it's comprised of three groups, ionized calcium, complex calcium, and protein-bound calcium. And you just get a total number, like 10. And 5 of that's ionized, 1 is complex, and 4 is protein-bound. But you don't know really the individual numbers, you just know 10. So this can cause a little bit of difficulty in interpretation. If you really want to know the ionized calcium, you can measure it separately by doing ionized calcium. But it's important that you know that on the profile, you're just getting the total. So, for example, one of the most common causes of total hypocalcemia on the profile is hypoalbuminemia. The reason being that normally about 4 grams or 4 milligrams per deciliter of that total calcium is protein bound, mainly to albumin. So if you have hypoalbuminemia, you can have a lower protein bound fraction, but the ionized fraction, which is the biologically active fraction, is normal. But that animal's total calcium on the profile is 8. And you're going to look at that and go, oh, it's low. So the first thing you need to do is look at the albumin. If the albumin's low and the animal's not symptomatic, that's probably why the total calcium is low. Here's just an opposite example of an animal with, say, most animals with chronic kidney disease have either a total calcium that's normal or slightly low because their ionized is usually normal or slightly low. But in occasional situations with CKD, you can have increased complex calcium and actually have total hypercalcemia. But again, look at the ionized. The ionized is normal, and sometimes the ionized can actually be low, and say this was 4, and this was 3, and this was 4, you would have a slightly low ionized calcium, but the total is increased because you've got increased complex calcium. So the situation with calcium in CKD is complicated by these issues. So hypercalcemia, what are the causes of hypercalcemia? Well, these are the most common ones: dehydration, certain malignancies, big ones being lymphoma, an apocrine gland adenocarcinoma of the anal sac, Addison's, some dogs with CKD, but not all, hypervitaminosis D, and primary hyperparathyroidism. My colleague, Dr. Chu, that I worked with for many years, came up with what he calls his hard ions mnemonic for remembering the causes of hypercalcemia, and hard water having a lot of calcium. That's the idea of hard ions. But I always tell people you have to think like Dennis to make this work. So if you think of Addison's disease as hypoadrenocorticism, which is its official name, not its eponym, you'll get all messed up. So you have to think like Dennis and call it Addison's to make hard ions work. And so anyway, but if you like the hard ions mnemonic, it's a way of remembering your causes of hypercalcemia. Hypocalcemia, as I said earlier, the first thing you want to do if your total calcium's low, look at the albumin. Especially if the animal's looking at you and having no clinical signs, look at the albumin. If it's low, that's probably why the calcium's low. Other causes of hypocalcemia, many dogs with CKD or cats with CKD can have a total calcium that's slightly low because their ionized is low, or it may be normal and their ionized might be low but their complex is increased. Remember, that's complicated. Ethylene glycol poisoning because of the metabolites that bind calcium and cause hypocalcemia, eclampsia, acute pancreatitis, and primary hypoparathyroidism, where you have not enough PTH, so you are not able to reabsorb enough calcium from the glomerular ultrafiltrate. Phosphorus, normal phosphorus in dogs and cats, and about 5 milligrams per deciliter, range of 2.5 to 5 or so. What causes hyperphosphatemia? I would urge you to look at phosphate just like you look at potassium. What determines extracellular concentration of phosphorus? It's the convergence of intake, excretion, and translocation again. And intake, orally, excretion is going to be through the kidneys, so anything that affects renal excretion of potassium, renal failure of acute or chronic nature, uroabdomen, where you're releasing potassium-rich urine into the abdomen and reabsorbing it, or obstruction where it can't get out, or hypoparathyroidism, which you don't have enough PTH, which normally helps the body get rid of phosphate in the urine, so it might be retained a bit, get hyperphosphatemic. Increased intake, like vitamin D intoxication. The main place we see these days vitamin D intoxication, at least in the States, is calcipotriene, which is a calcium analog that's in certain dermatologic preparations to treat psoriasis, and if the dog eats that, they can get hypercalcemic. And then you all, I'm sure, know that young growing animals often have mild hyperphosphatemia due to bone growth. It's normal. Other side of the coin, hypophosphatemia, translocation in the other direction from extracellular fluid to intracellular fluid. The main place that happens is when you're treating a DKA patient and you give them, again, insulin, and not only does glucose go into the cells, potassium goes into the cells, and what are the first two things that happen to glucose when it enters the glycolysis pathway? It gets phosphorylated. Glucose 1-phosphate, glucose 1,6-diphosphate. So it's like a sink for phosphate. So you start to use up phosphate. So if you're not careful, DKA patients can become hypophosphatemic during treatment, and so you got to watch that. Hypophosphatemia could be also decreased renal absorption. The big one there is primary hyperparathyroidism, where you have too much PTH, so you're excreting too much phosphorus in the urine. So when you see especially a Keyshound, a 6-year-old Keyshound that has a calcium of 14, and you look at the phosphorus and it's like 1.8, first thing you think about is primary hyperparathyroidism. Fanconi syndrome would be a relatively rare cause of hypophosphatemia. Since I'm in Australia, I have to say you guys were the first ones to identify the chicken jerky treats that came from China that caused the epidemic of Fanconi syndrome back a few years back, and it's now all over the world. So that was an Australian discovery. And then decreased intestinal absorption of phosphorus with malabsorptive diseases, vitamin D deficiency, or phosphate binders that we use in CKD patients could potentially do that. Okay, so I hope I'm doing okay if I'm going for 8:15, right? So we finished the electrolytes, and now we're going to move on a little bit to clinical assessment of GFR, something old, something new. The old stuff will be looking at BUN and creatinine, which we all know a lot about. We'll mention a little bit about clearance techniques, but as Graham said, they're laborious, they're tedious, they're difficult. And then we have a new test that Graham talked a lot about, which I'll try to reinforce some of what he said, the SDMA test. So let's look at the stuff we already know. BUN and creatinine are on all of our profiles, and we look at them every day. Okay, I apologize because I'm from from the United States, and we still use milligrams per deciliter. So I apologize. I know you guys use System International units. I kind of forgot that. So bear with me. Whoops, with the American units. So normal BUN in the States, we would say about 20 milligrams per deciliter, somewhere in that ballpark. It is a polar compound. So it's very soluble in water, distributed throughout total body water, and it's a way for the body to get rid of nitrogen. Where does it come from? Well, as you all learned in vet school, it's made in the liver, right? And it's made in the liver using ammonia that comes from the breakdown of proteins, whether they be endogenous proteins, body proteins, or exogenous proteins that come in through the diet. So herein lies one of the first difficulties with assessing renal function with the BUN, and that is it's affected very much by diet and by liver function, okay? So it's not produced at a constant rate in the body. After a meal, and you've got increased synthesis of urea with all that ammonia coming in the portal blood to the liver, the BUN will go up a little bit after a meal. Likewise, if you have liver disease and, say, a portosystemic shunt, and that portal blood is shunting around the liver, you don't synthesize enough urea, and the urea can be low. So urea is affected by meal feeding or anorexia. It's also affected by liver function, or the portal circulation getting to the liver like it should. Then let's look at how it's handled by the kidneys. Well, for something to be a good marker of GFR, we want it to be filtered and neither reabsorbed nor secreted. That is the gold standard for something to be a marker of GFR. Well, urea is freely filtered. It's not secreted by the tubules, but unfortunately, it does undergo passive reabsorption in the proximal tubules especially, and later in the nephron as well, due to how fast the fluid is moving through the tubules. So when the animal is really dehydrated, the fluid is moving more slowly through the tubules. There's more time for passive reabsorption. When the animal is really well hydrated or being diuresed, the fluid is moving really fast through the tubules, and there's less time for it to be passively reabsorbed. This is important because when you deal with really dehydrated animals, there is some passive reabsorption of urea that contributes partly to the increase in the BUN that you see. So BUN has kind of two strikes against it as a marker of GFR. It's not produced at a constant rate. It's dependent on feeding. It also depends on liver function. And then the way it's handled by the kidneys, unfortunately, it does experience passive reabsorption. So it's not the ideal marker for GFR. So you always have to pay attention to protein intake. Another thing that can cause the BUN to go up out of proportion here is hemorrhage into the GI tract. And the easiest way for me to tell students to remember that is hemorrhage in the GI tract is like a high protein meal for the bacteria that live there, right? And then they eat up all that protein, they produce a lot of ammonia, the ammonia goes back to the liver through the portal circulation, the liver makes urea, and the urea goes up. So hemorrhage in the GI tract is a cause of a mild increase in BUN out of proportion to the creatinine because of more ammonia going to the liver from the gut and being synthesized into urea. So using the BUN to evaluate kidney function, you always have to pay attention to those non-renal variables that we mentioned. And once you've eliminated those, you can focus in on the kidneys. Creatinine is the other time-honored test of renal function. It again is a water-soluble compound. It's a polar compound, so it's water-soluble. It's also a way for the body to get rid of a lot of nitrogen. And again, I apologize, milligrams per deciliter, but about 1 to 1.8 milligrams per deciliter would be normal. And that translates probably into, what is that in micromoles per liter? A lot higher than that. So anyway, creatinine is, where does that come from? Well, first of all, diet has no effect on it. Okay, it's not coming in through the diet. Where does it come from? It comes from muscle. And if you remember from your muscle physiology from a long time ago, there's a substance in muscle called creatine. And creatine is a way you transfer high-energy phosphates from ATP to ADP and put that phosphate on creatine to form phosphocreatine. It's a way for the muscle to store high-energy phosphate for times of need in muscular activity. So if the phosphocreatine loses phosphoric acid and cyclizes, you get creatinine, or if creatine loses water and cyclizes, you get creatinine. This is a spontaneous breakdown of the phosphocreatine and creatine that occurs at a very constant rate in the body every day. It's not an enzymatic process. It's a constant degradative process that occurs very constantly, dependent only on the muscle mass of the individual. So what determines the muscle mass of the individual? Well, the main things are, age, breed, and sex. So, young puppies, smaller muscle mass, slightly lower creatinines. As they get older, their creatinine's a little higher. Males tend to have more muscle mass than females, higher creatinine a little bit. And breed, like the greyhound or the really well-muscled dog versus the less well-muscled dog, they have a slightly higher creatinine. So it's the main thing that affects, the main non-renal variable that affects creatinine is muscle mass. And this becomes important when we talk about SDMA in about 15 minutes. Okay, so creatinine is freely distributed throughout total body water, and let's look at the way it's handled by the kidney. It is freely filtered, and it is neither reabsorbed nor secreted to any significant extent. So as far as the way it's handled by the kidney, it's great. It's a great marker for GFR. So its only problem is it's affected by lean body mass, okay? So the non-renal variables here, not particularly important because muscle mass is usually pretty constant at a given point in time. Now, if you went out around the Boston Marathon and somebody checked your creatinine right after you crossed the finish line, you probably would have an increase in your creatinine from rhabdomyolysis, but the next day it would be normal because the excess would be excreted. But so with creatinine, it's pretty easy to eliminate the non-renal factors as long as you pay attention to muscle mass. And then you can focus in on the renal factors. We mentioned those non-renal variables being primarily things related to muscle mass. So this is a picture that I'm certain you've all saw in veterinary school when you learned this stuff in vet school. So this is the relationship between GFR, which is the key renal function we're trying to get a handle on with all these tests, plotted against serum creatinine on the y-axis or BUN, in this case serum creatinine. And what we want you to notice is the shape of the curve. It's called a rectangular hyperbola, which just means the slope of the curve approaches zero out this way and approaches infinity that way. So what that means is you can lose a lot of GFR or a lot of renal mass before you see any increase in the creatinine or the BUN. And what you all learned in school and what you all remember is the BUN and creatinine don't go up in the blood until you've lost about 75% of renal function. And then once you get down below 75%, then the slope of that curve is getting steeper and steeper. And then every little decrease in GFR causes a big change in BUN and creatinine. But it's kind of like too late now, right? We'd really like to know what's going on out here because we would stand a better chance of managing the animal medically out here than waiting till in here. So the big problem with BUN and creatinine is they're insensitive. They don't go up in the blood until you've lost 75% of renal function. So then when you're considering the magnitude of azotemia, important to understand this relationship. But you can say then if the animal's in a steady state, in other words, things aren't changing, steady state, we didn't just finish the Boston Marathon, we're not vomiting, losing fluid that way or whatever, we're in a steady state. Once you're in a steady state and you've eliminated non-renal variables, an increase in BUN and creatinine implies that at least 75% or more of the nephrons are non-functional. Sounds like a very dogmatic, heavy-duty statement, but it's true. But I always would tell students, it's important to remember this, but it's just as important to remember what you can't say based on the magnitude of the BUN or creatinine alone, and what you can't.
BUN is normal and creatinine is elevated in the steady state.
Well, there are not too many situations where that happens. The reverse of that, where the BUN is elevated and the creatinine is not so much, happens because of some of the non-renal variables we said. But to see the creatinine up out of proportion to the urea would be pretty uncommon. Main place you would see that would be maybe in really well-muscled individuals. So what you can't say about the magnitude of azotemia is you can't tell if it's pre-renal, renal, or post-renal just from the magnitude of the BUN or creatinine. In general, it's true that pre-renal azotemia tends to be mild. Post-renal azotemia tends to be really severe, and renal is kind of all over the map. But if you take any one number from any one animal, whether it be a creatinine of 2 or creatinine of 4 or creatinine of 10, you can't say, oh, it must be pre-renal or post-renal. You can't say. Likewise, you can't tell acute from chronic. An animal with acute kidney injury can have just as severe of azotemia as one with chronic. You can't tell reversible from irreversible. You can't tell progressive from non-progressive from the magnitude of azotemia. So although it's important to understand that BUN and creatinine don't go up till you lose 75% of renal glomerular filtration, it's just as important to know what you can't say about one number. Okay, a few things about the concept of clearance, and then we'll conclude with some stuff about SDMA. So I don't want to focus too much on clearance because, as Graham said, it's not a test we do every day. First of all, I tell people, if you've got an animal that is azotemic in the hydrated state, is there any reason to do a creatinine clearance or an oxal clearance? Do you need to do that? No. If they're azotemic in the steady state, you know they're down below 25% of GFR. So doing this test would be a total waste of everybody's time, money, effort, and so forth. So you'd only do this if you had a patient that was PUPD, but had normal BUN and creatinine. You've ruled out other causes of PUPD like Cushing's, it's not a diabetic, you've ruled out liver disease, other things, and you start to think, well, maybe this is an animal that's lost concentrating ability but is not azotemic yet. And that's when you might do a clearance. So what is clearance? The definition of clearance is the volume of plasma that would have to be filtered at the glomeruli in 1 minute to account for the amount of that substance in milligrams per minute that's appearing in the urine under steady state conditions. So it's a complicated kind of definition, but the formula for that, to how you would calculate that volume of plasma, would be the urine concentration of X times the urine flow rate in mLs per minute divided by the plasma concentration of X. That would tell you the mLs per minute of plasma that would have to be filtered up the glomeruli to account for the amount that's appearing in the urine. So you can measure the clearance of anything, but the clearance of certain things has special significance. So the clearance of something that is filtered, freely filtered at the glomeruli, but neither reabsorbed nor secreted is very important because its clearance tells you the GFR. And you can convince yourself of that by some simple math. So, and that would be, if you're in a steady state, and if it's neither reabsorbed nor secreted in the tubules, and you're in a steady state, you're filtering a certain amount of this substance, milligrams per minute up at the glomeruli, and there's a certain amount coming into the urine, milligrams per minute in the bladder, and those numbers are equal. If it's not being taken out of the tubules by reabsorption, or it's not being put into the tubules by secretion, you can equate those two things, as I've done here. So the glomerular filtration rate times the plasma concentration, once you're in a steady state, if it's neither reabsorbed nor secreted, can be equated with the amount that's going into the urine per minute, which would be the urine concentration in milligrams per ml, say, times the urine flow rate in mLs per minute. So you got milligrams per minute equals milligrams per minute. All you do is divide both sides of that equation by P, and you see that that's the classic clearance formula. And so if the substance is neither reabsorbed nor secreted, the clearance equals the GFR. So we ask ourselves the question, what do we have in the body that's freely filtered and neither reabsorbed nor secreted? Creatinine, right? So creatinine clearance is a great marker of GFR that's right in the body already, and you can weigh the animal, you can get the owner in a dog to collect a timed urine volume by, you take the dog out, you know, at 9 o'clock at night, let it pee. They bring it into the clinic next morning. They don't let it pee in front of your clinic. You bring it in, put it on the table, let it pee, collect that urine, catheterize it, get the rest of the urine, add that volume up, measure the creatinine in that urine, measure the creatinine in the blood, weigh the dog, and you can calculate the creatinine clearance. Great. A little bit tedious, but you can do it. Cats, forget it. Can't do it at all, right? It's impossible. But creatinine clearance can be done, but as Graham said, what I just described is not the easiest thing for the owner or for you to do. So we don't do a lot of creatinine clearances. And now that we have other things, I'm skipping the inulin clearance because it's really just the gold standard. It's a research tool. It's the absolute gold standard for measuring clearance, but since inulin doesn't exist in the body, you have to do a CRI of it, and you got to collect urine, aliquots every 20 minutes. It's a laboratory tool. It's not a diagnostic tool. But there is a relatively new one called iohexol clearance, and the beauty of that is all you got to do is you give the iohexol, and you draw 2 blood samples from the animal, depending on it's a dog or cat, different times you take them, but 2 blood samples, send it to the lab, and you don't need any urine. And they come back with a number that's the iohexol clearance, which is an indicator of GFR. So that's a great test. The disadvantage of that is very few labs offer that, but some do. And the iodine is very stable in the male, so you can send it to a remote lab. So there are some clearance tests you can do, the creatinine clearance, the iohexol clearance, but the creatinine clearance is a little tedious. The iohexol clearance is not widely available at diagnostic labs. So in the last 15 minutes, we'll talk a little bit about SDMA, and a lot of what I say will overlap with what Graham said and hopefully reinforce that. And this is just a little bit about the biochemistry of these various compounds, and this is arginine here, and if this was an arginine residue in a protein molecule, you'll see that the terminal carbon there has 2 amino groups. So if you methylate one of these amino groups, as is shown here, you have what's called monomethyl arginine. If you then methylate the other amino group, and instead of this one, now you've got 2 methyl groups, but they're on the 2 different amino groups there. That's called symmetric dimethyl arginine. If you happen to methylate it a second time, but you methylate at the same nitrogen atom as before, you now have what's called asymmetric dimethyl arginine. Turns out that asymmetric dimethyl arginine is metabolized primarily by the liver, whereas symmetric dimethyl arginine is eliminated by GFR and is neither reabsorbed nor secreted and is eliminated almost entirely by the kidney, so it's a very good marker of GFR. So what I'm going to do in the last 10 or 15 minutes here is just kind of go back over some of the stuff that Graham already said and try to go over these, what I think are the 3 big points that I would want anybody to take home about SDMA. First of all, I want to just quickly go over a little bit of the literature that supports that it is a good biomarker for GFR. The fact that it goes up before the serum creatinine goes up, and lastly, that it's not affected by lean body mass. So first of all, is it a good biomarker for kidney function? Well, it's got to be as good as the existing ones. What are the existing ones? Serum creatinine, creatinine clearance, inulin clearance, iohexol clearance. So it would have to be as good as these are the first studies that came out in humans, dogs, and cats, And basically, without getting into a lot of detail, you can see here that in humans, dogs, and cats, SDMA correlated with both inulin clearance at about 85% and with serum creatinine concentration at about 75% in all 3 species. So in these 3 species, it is a good marker of GFR. I didn't dwell on that, but you could go back and read those research studies, and if you believe them, then hopefully you'll be convinced it is a good biomarker of GFR. But, and that's key background information you got to have and you got to believe to go forward. And if you believe that, then the next step is let's look at how it goes up in the blood relative to creatinine. This is one of the very exciting things about SDMA, is it's a more sensitive marker in that it goes up in the blood when you lose somewhere between 25 and 40% of GFR, as opposed to the creatinine doesn't go up until you lose 75% of GFR. So a huge potential advantage of being able to identify renal disease earlier, okay? So I do want to mention a little bit about this particular study, which Graham also talked about this study briefly, and that was a study in cats that was done by Gene Hall from Oregon using these Hills colony cats. And as you might imagine, Hills, because they're in the business of making pet food, has colonies of dogs and cats that they basically keep throughout these animals' lives. They collect a lot of data and a lot of banked serum and on these animals, and they live out their lives in this colony, and they are used to test the palatability of pet foods and so forth. And so it's a beautiful setting in which to follow animals throughout the natural course of their life. And what Dr. Hall did is she looked at these cats. Some of them got old and lived out their life in the colony, and they never developed CKD. Others, as they got old, developed CKD. And she then separated those groups and compared them. But what I want you to really remember about this study is she had to define what was CKD. She had to define that so she could allocate these animals to the 2 groups. She defined in this study, first of all, what did she use for her gold standard of GFR? She used the iohexol clearance. And she'd said that I'm going to call a cat a CKD cat if it has a greater than 30% decrease in GFR from the lower 2.5 percentile of the healthy geriatric cat. So the 2.5 percentile would be the tail of that bell-shaped curve. You had to be 30% or more below that for her to call it CKD. And so that was her definition. And then she looked at these cats and looked at their SDMA at various points throughout the course of their lives. And what she found that in this study was that on the average, the SDMA increased about 17 months before the creatinine did. There was a wide range, as little of only a month and a half before, but as long as sometimes almost 4 years before. But the average was about 17 months. So she was able to pick up a problem in these cats on the average 17 months before she would have picked up a problem if she was just looking at creatinine. This data is from that study looking at sensitivity, specificity. I know you probably get mad at me if I go back to epidemiology for 2 minutes, but how many of you learned about spin and snout? It must not be an Australia thing, but we learned in epidemiology about spin and snout. So snout means, and it's S capital N O-U-T. So a sensitive test, if it's negative, that's the capital N, rules it out. And spin is S with a capital P, I-N. Spin is a specific test. If it's positive, that's the capital P, rules it in. So that's an easy way to remember what sensitivity and specificity mean in a qualitative way. There are mathematical definitions for those things. In 35 years, I've never been able to remember them. So I remember spin and snout. So, and we'll focus on those. These are positive and negative predictive value, but we'll focus on sensitivity and specificity. So in this study, what she found was that SDMA had 100% sensitivity, very sensitive. Creatinine had a lousy sensitivity. Does that surprise you? It shouldn't surprise you at all, right? Because the creatinine doesn't go up in the blood till you lose over 75% of GFR. It's a very, just from that curve, it's a very insensitive test. And that was borne out statistically here. So remember, sensitivity, a sensitive test, if it's negative, rules it out, snout. So that tells you that if you've got a normal SDMA, you can take that to the bank that you do not have decreased GFR in that animal. Snout, sensitive test, if it's negative, rules it out. So that's very helpful information. Specificity of creatinine is 100%, right? Because it's a very specific test. If the creatinine's abnormal, you can take it to the bank. If the creatinine is normal, you can't take it anywhere because it's not very sensitive, but it's very specific. Now, the specificity of SDMA in this study, as defined by Gene Hall, was very good. It was not 100%, but it was very good. But IDEX wants to make sure that you look at the asterisk. Why is that? Because going back to how did she define CKD in these cats? She said, I'm going to call them CKD if their GFR, as based on iohexyl clearance, is greater than or equal to 30% below the lower 2.5 percentile of normal. Well, there were 2 cats in this study where the GFR was decreased by only 25% below that, not 30% below, but 25%, and she called those false positives, okay? But how do we know they were false positives? They could have been cats that actually did have the beginnings of progressive renal disease, but because of the way she defined CKD versus non-CKD, they were considered false positives. Does that make sense? So all I'm saying is the specificity of SDMA in this study was at least 91%. It might have been more depending on those 2 cats, whether they were truly false positives or whether they were true positives. Okay. Similar study she did in dogs. Graham showed you this data as well. And in this study, SDMA increased in these dogs on the average of about almost 10 months before creatinine went up. Again, a very wide range, 2 months to 2 years, but average of 10 months. So very, very exciting to me that here's a marker that will detect decreased GFR somewhere between 20 to 40% decrease in GFR instead of waiting to get down to 75% loss like with creatinine. Very exciting. And the last point I want to make in the last few minutes is this issue of lean body mass. Okay, and Graham mentioned briefly that you can measure well, in a laboratory setting, you can measure lean body mass by DEXA scanning, which is what Gene Hall did in this study. And I want to focus a little bit on this study. And she looked at 3 groups of old cats, and I'll call them really old cats, kind of old cats, and yeah, somewhat old cats. Okay, 3 groups. So less than 12, the average age here was 10 and a half. These guys were 12 to 15. These guys were really old, like, over 15. And she looked at their GFR, and these are just old cats. I'm not saying anything about their kidneys, okay? They're just old cats, okay? And she looked at their GFR. She used iohexol clearance as the gold standard here. And she looked at their lean body mass as measured by DEXA scanning. She looked at their serum creatinine, milligrams per DL, and she looked at their SDMA. Okay, so what happens here is you go from being a kind of old cat to a somewhat old cat. Your GFR is really not significantly different. But when you get to be a really old cat, like over 15 years, the GFR goes down. That's not to say these guys are in renal failure necessarily, or but their GFR is significantly lower than it was when they were somewhat younger, okay? Significantly lower. What happens to the lean body mass? Well, again, the first 2 groups of cats, not significantly different. But when they get to be really old cats, their lean body mass is significantly lower than when they're younger cats. This is true of most species. As animals and humans get older, we tend to lose muscle mass and lean body mass. So let me ask you this. Forget about the lean body mass. Let's say you didn't know what it was and you assumed it was the same in old cats as it was in young cats. You didn't know. If the GFR went down significantly in this old group of cats, what should their creatinine have done? Their serum creatinine. Should have gone up, right? Right, because if the GFR goes down, serum creatinine goes up. So you would expect the serum creatinine would have gone up in these cats. But look over here. Wait a second. Their serum creatinine was actually significantly lower, not higher. Why is that? And what's the answer?
Lean mass.
Exactly. Lean body mass went down. And so what this is telling you, what this tells me is when you have an old animal with decreased lean body mass, the serum creatinine has the potential to lie to you about renal function, and you have to be very careful. It's really important with the old skinny hyperthyroid cat, like Graham mentioned, and he gave you some data on that. But look at the SDMA. So the SDMA in the first 2 groups, again, is similar, but in this old group who lost lean body mass and the creatinine went down, the SDMA went up, just like it should, because it's not affected by lean body mass. So this is the third point I wanted to make about SDMA, and again, to me, something that's very important about it from usefulness diagnostically. It's going to not lie to you in old animals with decreased lean body mass. So the only last point I'll make, and Graham talked about this, but you know, one thing that really freaks people out is rarely, maybe 1 to 2% of the time, you'll get a situation where the creatinine is a little bit increased and the SDMA is normal. And the first thing people do is freak out and go, oh, it's a terrible test. That doesn't make any sense. And it doesn't make any sense. But as Graham pointed out to you, one reason this can happen is hemolysis. And I don't understand why hemolysis causes the SDMA to go down, but it's one reason that the SDMA could be normal and the creatinine could be a bit high. The other big reason is muscle mass, okay? SDMA is not affected by muscle mass, so it's not going to change with a well-muscled individual. Whereas a well-muscled individual, greyhound, a mastiff, a really, you know, a very muscular dog, they might have a slightly high serum creatinine that's normal because of their muscle mass, but their SDMA won't be affected by that, so it might be, you know, lower. And so there are reasons why that 1 to 2% of the time you'll see this discrepant result. And it's not a reason to throw the test out. It's not the problem with the test. It's just understanding that there are methodologic things and things about the animals that can cause it to happen. So I think if we're going by 9:15, I have 3 minutes, so I'm done.